Hello, welcome to everyone. I'm Dr. Gopal, an infectious disease specialist. Welcome to Zooming through ID. Um, I am practicing here in South Florida. I trained at Duke University. It's almost a little over 20 years I've been doing infectious disease. I chair the infection control, and I'm also the chair for antibiotic stewardship at the Broward. I teach internal medicine residents. And Zooming through ID is an opportunity that I've created to nurture intellectual curiosity among residents. They pick a topic of interest, and this is where they showcase what they have learned. Um, we also have a fellowship program here, and I am the APD for the Infectious Disease Fellowship. Today, we are going to talk about very interesting topic, neurocysticercosis, and I am joined by Annette. She rounded with me, and she's excellent. She is very passionate, very sincere, and a great bedside manners. And she is going to talk today. So I will introduce you all to Annette. Annette, you can start.
Yeah, hi, nice to meet everyone. Yes, my name is Annette Matthew. I'm originally from Chicago, Illinois, but I'm currently doing my internal medicine residency at Broward North. I went to medical school at Nova Southeastern University and very passionate about medicine and infectious disease. I did rotate with Dr. Gopal and I learned a lot, and it was definitely an interesting topic. And so, kind of leading into that, I saw two cases, not with necessarily Dr. Gopal, but previously on rounding, where there were individuals diagnosed with neurocysticercosis on imaging. So I wanted to dive a little bit deeper into that topic. And so I created this presentation. And so I hope everyone's able to learn as much as possible through it. Okay, so I'm going to share my screen. Share. Let's see if everyone can see. All right. Dr. Gopal, can you see this?
Yes, yes.
Perfect. Okay. So again, kind of like I discussed, my presentation is about neurocysticercosis. I made a little table of contents just to kind of discuss what we'll be going through, over mainly the overview, pathophysiology, some clinical presentations of this disease, along with diagnosis, treatment, and case study. Okay. So our overview. So neurocysticercosis is a preventable parasitic infection caused by larval forms, cysts of the pork tapeworm Tiniosolium. So cysts can cause infection in various parts of the body, and that's considered cysticercosis. And then the infection of the brain is considered, or any CNS structure at that point, is neurocysticercosis. It can lead to seizures and may also be fatal. So I pulled some statistics. About 2.56 to 8.3 million people are affected worldwide. 20% of individuals in endemic areas are without treatment of this disease. And the mean age of death is 40.5 years old. So very young. So the next thing I want to go over was the pathophysiology. So kind of discussed here, I pulled this image from the CDC. The intermittent host would be the swine or pork, and then the definitive host is humans. So Tiniosolium affects both pigs and humans as hosts. Pigs become the intermittent host by eating embryonic eggs from human feces in places where feces disposal is deficient. So the parasite then hatches and invades the intestinal wall, enters the bloodstream stream of the pig, and migrates to multiple tissues, such as striatal muscle, where they become cistercerci. After human consumption of undercooked pork meat, the cerci hatch in our small intestines, and the tapeworm attaches itself to the intestinal wall through its scolex. Then humans are infected. It can go to various portions of the body and infect the muscle, and at some point infect the brain as well. Humans can also become intermittent mediate hosts by eating vegetable, fruits, or drinking water that is also infected by these Taenia solium eggs. There can also be human-to-human contagion as well. The most affected organs are striatal muscles, subcutaneous tissues, the CNS, and the eyes. So that's pretty much it, the pathophysiology. So there are three main forms when I did some reading of neurocysticercosis. It can be an extraneural form, an intraparenchymal form of the brain, and an extraparenchymal form of the brain. So the most common forms include muscle and subcu tissue. What you see is normally 0.5 to 2 centimeter asymptomatic nodules, which can cause discomfort when they're inflamed. And then on radiography, they're described as cigar-shaped calcifications. Additionally, it can also affect the heart and cause arrhythmia. So that's of the subcu tissue and muscle tissue. The other form is the intraparenchymal version. So the onset of symptoms of neurocysticercosis occurs about 3 to 5 years after infection. And in the intraparenchymal form, epilepsy is like the most common manifestation. However, you can still have headaches, focal deficits, cognitive and psychiatric symptoms as well. And this is also the most common form of cysticercosis. And when the cysts are located in the extraparenchymal compartment, the main symptom is intraparenchymal hypertension. So you get increased ICP. These manifestations are slowly progressive and related to parenchymal cysts or large subarachnoid cysts compressing the brain parenchyma. So you get symptoms like headache, vomiting, nausea, and sometimes altered mental status. So when discussing the diagnosis of this, there are major and minor criteria. So absolute criteria I have included here an image from UpToDate. So a histologic demonstration of the parasite from biopsy of the brain and spinal cord is an absolute criteria for diagnosis. If you can also see it in someone's eye, so visualization of subretinal cysticerci. So this is typically a more specialized exam and when you would get ophthalmology involved, which is something that I ended up doing in one of the cases that we saw, and ophthalmology actually did not see any of the cerci within this patient's subretinas anyway. And then also a final absolute criterion is conclusive demonstration of the scolix within a cystic lesion on neuroimaging. So I personally have never seen it, but it is an absolute criteria. So major criteria for diagnosis is cystic lesions with no discernible scolix, enhancing lesions, which is sometimes most likely what you'll see. That's what I've seen in 2 of the cases that I was involved in. Multilobulated cystic lesions in the subarachnoid space are typical parenchymal brain calcifications. Confirmation criteria is the resolution of cystic lesions after drug therapy, spontaneous resolution of single small enhancing lesions, and migration of ventricle cysts documented on sequential neuroimaging studies. And a minor criteria is obstructive hydrocephalus or abnormal enhancement of basal leptomeninges. So those are the neuroimaging criteria. There's another criteria. It's the clinical or epidemiologic exposure criteria. So major criteria is detection of specific anti-cysterical antibodies or antigens by well-standardized immunodiagnostic testing. So that would be like PCRs. And then neurocysticercosis seen outside of the central nervous system, and then also household contact with Taenia solium infections. And then the minor would be clinical manifestations suggestive of neurocysticercosis, and then individuals with prior or current residence in an area where cysticercosis is an epidemic. And so I know I've given you a lot of criteria. However, in order to make the diagnosis, these are the diagnostic criteria. So definitive diagnosis is either the presence of one absolute criteria or the presence of 2 major criteria with 1 minor or 1 epidemiologic criteria. And then you can also have a probable diagnosis based on 1 major with 2 minor criteria, 1 major plus 1 minor and 1 epidemiologic. or 3 minors with 1 epidemiologic criteria. So that's just a combination of the few criteria that we've discussed here. So I pulled some images as well. So here you can see multiple viable cysts with the scolix, or the actual parasite inside of it. Another one here is a single enhancing lesion, a degenerating cyst. So viable cysticercosis don't cause actually a lot of inflammation in surrounding tissue, and typically do not enhance after contrast administration. They can also degenerate when attacked by the host immune response. So the cyst wall increases in density and is often accompanied by surrounding edema and or contrast enhancement. Findings reflect the host inflammatory response against the parasite and are frequently associated with seizures. In many cases, enhancing cysticerci retain features of viable cerci, such as a ringing enhancing lesion. When the cyst fluid begins to increase in density, the cysts are thought to be no longer viable. So here as well, I've shown multiple intraparenchymal calcifications on imaging. And then here you see an intraventricular cysticerci. So non-viable cerci are usually non-enhancing, but may be associated with perilesional edema in some cases, and they're often associated with seizures like we've previously discussed. Here you see basal subarachnoid cysticerci, and then here you see massive parenchymal cysticerci. Finally, I just wanted to include non-radiologic images. So here, I'm not the best at my eye exam, but if you're able to see the ocular cysticerci here in this image, and then finally you can see the cigar-shaped calcifications here in the muscle. So now that we've discussed kind of the clinical presentation and the diagnostic criteria, I wanted to talk about initial management. So for someone who's having elevated intracranial pressure, and this is what you see typically in the extraparenchymal manifestation, you get diffuse cerebral edema, and the management involves corticosteroid therapy. So dexamethasone 0.2 to 0.4 milligrams per kilogram per day is what you would get. If you have obstructive hydrocephalus, you may have to undergo like surgical removal of the cysticerci or placement of an EVD. So finally, if you have a communicating hydrocephalus, a VP shunt may be used. And then, so that's one portion in terms of the management, and that's regarding managing elevated intracranial pressures. The portion of it is the anti-seizure medications. Even in the case of a single seizure, it should be managed with medication. So this, kind of like we've discussed, the infection can serve as a nidus for recurrent infections and recurrent seizures. So you can get focal epilepsy. So the recommendations involved phenytoin, carbamazepine, Keppra, levetiracetam, or lacosamide. And lacosamide is seen to have a better effect in children. Okay, and then I also wanted to say about that slide as well, signs and symptoms of increased intracranial pressure are nausea, vomiting, papilledema, somnolence. Okay. So parenchymal disease. So prior to undergoing the antiparasitic therapy, ocular disease should be excluded. So another reason to get ophthalmology on board so they can visualize and see if there is any ocular involvement. Another thing that you would have to do prior to undergoing corticosteroid therapy, they should undergo screening for latent TB and therapy for strongyloidiasis. Okay, and then antiparasitic therapy is warranted for patients with viable or degenerating cysts on neuroimaging. So you should not administer any antiparasitic therapy if there's untreated hydrocephalus, diffuse cerebral edema, and then the presence of calcified lesions only. And so patients with only 1 or 2 cysts, they recommend 7 to 14 days of treatment with albendazole, 15 milligrams per kilogram daily in 2 doses. And then for patients with 2 or more cysts, for 7 to 14 days, these patients would get albendazole, again, 15 mg per kg daily in 2 doses for 8 to 10 days. And then, or you can also do, on top of that, you would also do praziquantel, 50 milligrams per kg in 3 daily doses for 10 to 15 days. So a little bit about these two medications as well, albendazole and praziquantel. So the albendazole interferes with the glucose intake of parasites and depletes their glycogen stores. It also affects the production of ATP, which is the energy that they use for survival in the helminth. So it's poorly absorbed by the GI tract, but after absorption, it's converted in the liver to albendazole sulfoxide, and then the main active form of the drug. This is the main active form of the drug, and it's distributed throughout the body. So administration of the albendazole with a fatty meal also significantly enhances its bioavailability, along with if it's it enhances its viability, and then administration with something like cimetidine would decrease the viability of it. And some main side effects of albendazole is reversible alopecia and then maybe a mild transaminitis. And the transaminitis is possibly explained by the absorption and conversion in the liver. And then about praziquantel, they recommend that you administer praziquantel with a high carb meal, which enhances its bioavailability. And then I just included an image here of different pathways that you could go about treatment of this disease. It's just a pathway here, but this is something that we've already discussed. So we kind of talked about intraparenchymal management. So like we discussed earlier, extraparenchymal disease management is also different. So you can have obstructive hydrocephalus due to the intraventricular cysts. So intraventricular neurocysticercosis and hydrocephalus are associated with altered status or impending herniation. So CSF diversion via ventriculostomy, a VP shunt, or a cyst removal, or ventriculostomy. So you would also do albendazole 30 mg per kg per day in 2 daily doses for 10 to 14 days and an anti-inflammatory therapy with corticosteroids. So you can have communicating hydrocephalus due to subarachnoid disease. Again, you would put a VP shunt followed by antiparasitic and an anti-inflammatory. You can have giant subarachnoid cysts. So for this, you would manage with corticosteroids, and surgery is rarely required. For a spinal lesion, you would do steroids with an antiparasitic therapy. For an ocular lesion, you would do surgical removal, albendazole, and steroid management. And then anything outside of the CNS, management in the sub-Q or intramuscular circuit consists of NSAIDs. And then this as well is another pathway that we've kind of just discussed now. So I included a case study. Mr. JL presents to the emergency department after experiencing 2 generalized tonic-clonic seizures within 3 days. Each episode lasts about 2 minutes, followed by confusion and fatigue. He denied any fever, trauma, drug use, or prior neurological symptoms. He reported occasional mild headaches over the past month, but no nausea, vomiting, or vision changes. Additionally, Mr. JL immigrated to the U.S. 6 months ago from a rural area where pork is commonly consumed and sanitation is limited. He recalls occasionally eating undercooked pork in his home country. So the physical exam, he's ANO times 3, afebrile and no distress. Blood pressure is 122/76, heart rate of 80, respiratory rate of 16, and then temperature was 36.8. He had a normal cranial nerves on physical exam. Strength was 5 out of 5 in all limbs, normal coordination with no sensory deficits. Otherwise, his other systems were unremarkable. His laboratory results showed that CBC, electrolytes, and glucose were all within normal limits. The HIV test was negative, and then his serology, the ELISA testing, showed positive tinea-solium antibody. So, we also talked about like MRI brain imaging with contrast. So it showed multiple small ring-enhancing lesions in the parietal and temporal lobes, minimal perilesional edema, and some lesions showed central calcification suggestive of dead cysts, and there was no midline shift or hydrocephalus. So for him, the acute management involves Keppra for seizure control and steroids to decrease inflammation. And then this individual, he would undergo albendazole treatment 15 mg per kg per day for 10 to 14 days after 1 to 2 days of steroids. And then these are my resources.
Okay, it was excellent presentation, and you pretty much covered everything. Um, so just to sum up, I mean, tinea, we have to remember tinea solium. So I kind of remember the way like so, SO, there is a O there, and then pork, there is a pork, there is PO there. And this is a treatable cause of seizures for young, we see that in young people. Key findings, just to sum up, travel to endemic area is very important. So it will be person from Mexico or El Salvador coming in with seizures. Imaging study will help always. One of the things I've heard from many people is, oh, they will say they're traveling to Mexico, but oh, I don't eat pork. So then they think that they are kind of immune or they won't get neurocysticercosis, but that is wrong. The way the fecal-oral transmission when they eat. Like salad or fruits, if it is not washed properly, if it is contaminated with the cyst, that is that is the main mechanism. So they have to make sure when they travel to endemic areas, make sure they use bottled water and use cooked food. Those kind of prevention is important. The other aspect is, like you mentioned, when we see cases, very important to recognize the ocular syndrome and very important to call ophthalmologist. The other aspect is the inflammation caused by when we give anti-parasitic medication. The inflammation can cause really bad damage. So the anti-inflammatory steroids they use for that. And then the key drugs, albendazole, and praziquantel, you already touched upon that. So this was very nice and excellent job. So I will see you around, but thanks everyone for joining. Okay.
Thank you.